Well, welcome, Bart. Thank you so much for joining us today and talking through some case scenarios with regards to case conferencing.
Wonderful. Thanks for having me. It's good to be here.
Tell me a little bit more about yourself.
Yes, well, my name's Bart. I'm a physiotherapist. I'm based in the Illawarra. I've been practicing for a bit over 10 years. Throughout that time, I've sort of worked through some both community work and residential aged care work, where I find predominantly based myself at the moment. So working out of clinic-based practice, but then spending a fair bit of time with our older adults as well.
Fantastic. And so we have some really exciting things happen 1st November, right, last year, where Allied Health finally, it makes so total sense to us, doesn't it, has item numbers, MBS item numbers that they can now claim when they're participating in a case conference. Well, how was that day for you when you found out that finally you're going to get paid for some time that you probably already dedicate?
Yeah, it was really important actually, and yeah, you referenced obviously we get paid for it, but I suppose it's actually it's the recognition for the work we do, and then you know what, if I'm honest, it's then going to prompt us to be able to explore that area a little bit more as well. So I suppose if I take a step back, a lot of what we learn around being allied health providers is that multidisciplinary approach. And there's certain sectors that have done it very well for a long time. And I think the public sector is something we should be looking closely upon. But then once we get out into the sector that I'm in a little bit more, where it's a little more privatised, whether that be community or residential aged care, that has fallen away. And the release of these MBS items has been huge for us because it's enabled us to put our foot forward as well. And I suppose a little bit more background. We have physios and EPs. We have allied health assistants working with us, dietitians. So it's enabling them to be part of the bigger picture, which is then going to essentially in the end help all of our patients, clients, residents across the board. So it was a big day. It was really important for us.
Yeah, and when you think about case conference in relation to, say, diabetes, how could you see that being advantageous for a client, either a resident in a residential aged care facility and also in a general practice setting? How could that sort of look and work really effectively?
Yeah, sure. I suppose it's a really big one for us because I'm really big on professionals being great at what you do really well. Okay, so in the instance of diabetes, that's such a multidisciplinary approach that's required, and there's so much that comes from both the general practitioners, whether it be then the dietitians, and then myself as a physio. I know that I've got so much that I can contribute to a patient who has diabetes. It's not something that they're going to be dealing with for a short period of time, so you need to be part of them, you need to be invested with them, you need to be part of the big picture, and being able to tie yourself in with those other allied health professionals and GPs is a really important part to that. So then I suppose you also are aware that you can maximize your abilities and what you can work with the patient, but at the same time then understand what's happening else in the other parts of their life and what they're getting worked on from other professionals, which is equally as important. So then you actually know that's taken care of as well. You can focus your scope in on what you need to do with them, and then where possible refer and look after and as well gain knowledge of the other health professionals as well.
Yeah, and I think that really speaks to not working siloed and making sure we're not duplicating care, making sure we're really clear on who's doing what bits, where are the gaps, where can we start to fill those gaps as a preventative approach to minimise, hospital admission for a client.
Yeah, I think that's another big step because there's a lot of crossover in what we do in the community, and I think if we actually could hone in on that a little bit more, we're probably going to streamline the care for our patients or our residents in particular. I think often they get almost lost in the system a little bit because they get referred back and forth. But if we have that streamline where you can work independently, but then with the understanding and knowledge of what others are doing, it's going to help the overall care a lot more. And yeah, that's going to then translate into better health outcomes and might keep people, whether it be at home, keep them out of hospital, keep them out of residential aged care facilities, or empowering, family members as well. So it's a really important part to it, I think.
Yeah, and I'm thinking, your exercise physio team can be involved in this as well, right? Because exercise phys, they might be doing group sessions, or they may actually just be doing, a rehab type approach with a client as well. And everyone actually able to get answers in real time is going to save everyone a lot of time, rather than picking up the phone, having a conversation with you, Bart, and then saying, oh, well, now I'll ring the dietitian, then I'll ring the GP, right? You can't claim for that. It needs to all be in one. So if you're posing a question, it might trigger another question and it might resolve something else in a very time efficient manner.
Yeah, I don't know any situations where sitting in a room with it's almost like you've got the old butcher's paper up, and you've got your patient or your resident as the key focus point, but in the end you're pulling on each other there and then. And whether or not it answers the question there and then that you had, but it also may answer a question there and then that you didn't have, that you're about to have next time you saw them or the time after you saw them, or prompt your level of to change your level of care to a different streamline or whatever it may be that you're doing. Yeah, there's a lot to be had from being able to sit around the round table in a room. And I think EPs in particular, I see obviously diabetes is one instance, but there's a lot of other instances and conditions that we see throughout the community and in residential aged care facilities where I think they have a really important role to play. Physios for a long time have been doing a really good job, and I commend them on that and hope we get to continue to do that. But as someone who's very health focused and allied health focused, I suppose, I see EPs finally actually being able to grab their own 2 feet, and they're getting recognised in these environments. And the more they can come into case conferencing and the likes is really going to build up. And not only their own, EPs know what they can do, right? They know their profession and they know their skills. There's actually a bit of a lag period in what we as health professionals and then as an ageing population understand what an EP does. Back in the day, and I remember even 10 years ago when I started, a physio was seen as, oh, I'm not sure, I'll take the advice from my doctor, even though it's for a sprained ankle or a torn rotator cuff. Whereas now that people are going, oh no, physios, that's their place, that's their domain. And now we're seeing a similar thing with EPs coming through with, wow, we can do these group classes, we can do this exercise prescription that's going to help me with my diabetes for many years to come. And they're sitting around a round table, and they've got, whether it's their sons, their daughters, their mothers, their fathers, sitting around with them with their GP, their physio, potentially their dietitian, and so on, doing really good things.
Yeah, and I'm thinking about, chronic pain, Bart, and, people who have got cancer, all of those sorts of rich discussions, as you just made mention. You can have carers and family input. And the beautiful thing is I can be virtual, right? And so can you,
yep.
And so can the GP, and so can the care coordinator at the residential aged care facility, and so can the GP nurse, right? Everyone can meet, and we can actually get through a lot of detail about customising this approach so that it's patient-centric or resident-centric. Right, so that we're all going, how can we best support this person? And from a caregiver, that must be a lot of comfort for them to know that they're involved in the decisions and transparency about where we're headed in this person's, well-being journey.
I think it's probably the most important part is actually that involvement, because we're dealing with a lot of chronic conditions in our country, in the world at the moment. And for someone to live with a chronic condition, they have a lot of questions, they have a lot of frustrations, it's their life that they're going to be involved in for a long period of time. They need to have the full trust that all of their team, and we are a team, then that's what is the best part about it, I guess, is when you're case conferencing and you're empowering each other to deliver the best care, the patient and their family members then feel like they're feeling the love, right? They're like, wow, I've got this team behind me. Yes, I've got this diagnosis, and obviously we work through that with them, but they're like, wow, I'm in good hands, and they're listening to me, I'm listening to them, and we're really going to get the best out of this that we can.
And I know, particularly from my experience, Bart, and I'd love to hear your thoughts on this, people with complex needs, right? These are the people we're targeting with case conferencing. Their story is complex. And so when you've got a complex story, often you shortcut bits. Yep. So bits get missed out. And then it takes you a lot, doesn't it, of work to find out those missing pieces of the puzzle. It doesn't make sense in some way. So having everyone around one table, everyone's clear on where we're headed and what people's diagnoses and next steps are and goals and plans, that all that preventative pathway is mapped out in discussion and collaboration with each other. I think that resolves a lot of that duplication as well, and burnout for that person, that's having to tell this story over and over and over and over again.
Yeah. And I think also on that, it keeps it thorough, and you alluded to it at the start then, is we probably, I think in the community sector and the residential sector, we lose sight of the distant medical history and then the past medical history and the family history and the social history. Again, public sectors, I think, typically keep those records quite well. And I think it does come down to that multidisciplinary approach, because they have the right people in place working through that strategically as it happens. Whereas, as you've just alluded to, that little thing where, I don't know, say it's a physiotherapist and someone's really struggling to get up their stairs in their house, and if that minor detail, which in the end is a major detail, going, oh wow, they're in a 3-story home, we really need to be rehabbing them to be able to get from their kitchen to their bedroom. You can't let really vital information like that slip. Whereas around a round table, it just keeps coming out. And case conferencing really opens up those avenues to make sure you're keeping on top of all of the relevant history. And yeah, the patient isn't sitting there duplicating, going, I told someone this yesterday, I have 3 stories and I can't get home to that until I can walk up them, or that's what I need to be able to do to be able to get to the shower. It's important information.
Yeah. And I'm just wondering, from your perspectives, what do you think will be essential to make sure that case conferencing for allied health, whether it be in general practice or RACS, what do you see the essential ingredients to make a success?
Yeah, a good question. And there is challenges. Like, we can speak really positively about it, and it is a positive thing. Don't get me wrong. And I suppose we were nothing without at least the MBS items coming through. So that's super important. But if we're quite frank about it, we now need buy-in. So we need me as the physio to go, I'm still going to prioritize that time. It is a little bit of a switch. I have to go. Historically, I wasn't putting aside that time to catch up with all of these allied health professionals. But then we need the buy-in from the rest. And I suppose when we read the fine print as well, a lot of it has to be driven by the GPs. They are still seen within a leader, and rightly so. They study hard, they work their backsides off, and they do oversee the care for a lot of our patients and our residents. So the GP, look, they simply need to be doing the referrals. That's the important part for us. We need to be part of the case conferencing through their referral process. But apart from that, it's up to all of us then to prioritise it, to actually get it recognised and utilised to its full capacity throughout the community and the residential aged care facilities, in my opinion.
So I'm hearing relationships are key.
Yeah, for
relationships
sure.
And you having good networks around who might we utilize case conferencing for, how might we get it happen as a workflow so that it's not burdensome on any party, so there's buy-in and value for both parties.
And it's chicken and egg, because with this comes relationships, right? So the more you do it, the relationships then come quite easy, because if I go, oh, I'm catching up with Kim today and we're discussing patient X, we go, oh, yeah, that's easy. Kim and I catch up all the time. We're discussing our patients, our residents quite frequently. So that builds the relationships. But at the same time, it also means that you have to make those efforts earlier. And I think there is probably a little bit of a gap as to where that's happening at the moment. Again, I think it comes down to how we're prioritizing things, but also there's a lot of different healthcare providers out there and a lot of streams of healthcare provision. And so, for example, in the community, you may be working with one patient who has, if we go back to a diabetes example, that they've got one GP, and then your next patient with diabetes has another GP, and one's seeing one dietitian, one's seeing another. So there is an element that maybe we need to be working on streamlining our levels of care as well, and who's looking after particular types of clients. Again, that'll help them in the end as well, because they're going to be getting the best available care. They're going to be walking into a team that's already got built relationships within there. But no, I'm all for relationship building in healthcare, because I think it's the key to the success for the patients, that's for sure.
Yeah, and I guess probably from your perspective as well, if you were going to do one case conferencing, having a few booked in sequentially may be of benefits. You can carve out time, and that's what we're advising in our workflow with Rivka Hagen and myself, is saying, get 2 or 3 done at the same time with the same team members, right? Like what you just highlighted, rather than having different GPs and different people, and you try and coordinate everyone on one day. Maybe the GP that you're currently working with, you might have 2 or 3 clients that this would be appropriate for. Do those on that day, another GP, or maybe another day. Your complex pain people and cancer people, don't forget about your pharmacy team, right? That could be of great value, no doubt, to you as an allied staff member, to hear what kind of medication they're on and what the justifications and rationale behind that are.
And that's a perfect example, just to jump on that one. If I'm honest, the pharmacy side of things, the pharmacological care is so important, but how often do I as a physio just go, oh, yep, have you spoken to your GP and your pharmacist? Great, they're looking after that. And that's the end of that. I will ask, maybe what medications you're on, of course, but really I'm not involved. I'm just hoping I'm doing what I need to do, going, great, someone's looking after that, but I'm going to move on to mine. But if I'm sitting around that round table again, then that's going to help that a lot. Just to go back to the first point you touched on there as well, in terms of I suppose just efficiently working with our other health professionals. I have had some discussions with GPs in residential aged care facilities, and we've sort of looked at the best ways, because a lot of your residents are there for fixed amounts of time, whether it be 2 or 3 years. And we've talked about whether or not you do sort of quarterly reviews. So it's actually you lock in the date and you go, all right, well, said GP, you've got 15 or 20 residents at this facility. As a physio, I'm looking after most of those, which again, in those institutions, it's actually quite feasible, and it is easier because you generally will have one physiotherapist or one organisation looking after the residents, one exercise physiologist, and so on. And sure, then you might go, great, 4 of them have OTs, so we're going to from 9 till 10 or 9 till 10:30, we're going to see those residents bring in the OT. So it has to be efficient as well and feasible. But I think the way the MBS is structured, it means that we can do that.
Yeah, I agree. And I think that you've tipped on a really important point. If we don't use it, guess what happens, right? They disappear. And we always say we would really, really be able to do case conferencing if we have the item numbers. So knowing that we've got the item numbers is one thing. We've got the workflow within this package for everyone who's watching this today. But get out there and start to utilize these services, because otherwise, if we just say, yeah, it sounds good in theory, I just don't know how to go about it, and never utilized, it'll disappear. It'll be one of those item numbers that just fades away again. And I think particularly, we know the value of having really rich collaborative discussions with interdisciplinary team members. That in itself is a hospital avoidance strategy, better patient outcomes. That's what we're all striving for.
Yeah, and on that, and look, I'm pretty strong on this, and I actually urge my fellow health professionals and GPs to use the funding, because historically it is sometimes hard. Healthcare providers go, oh no, it's okay, I've got that bit sorted. But again, this is to maximise the care and the outcomes for our patients. There's people much smarter than I, looking at the numbers much closer than I, that have gone away to go, look, there is a need. We are putting budgets towards this. We need to be using it. It is our obligation for our patients, for our communities, for our mums and our dads to be using this. So if you're wondering if your resident or your patient requires it, then jump on the phone, talk to your GP, and I'm sure within 2 minutes of conversation you're going to go, wow, let's get together and have a chat about this. And hey, how about we bring in the osteo or the chiro or the whoever else is involved.
Yeah, great wrap up, I think, there, Bart. It's been such a pleasure listening to your insights and wisdom on this point, particularly from an allied health perspective, and we really are grateful for your time today.
Thanks, Kim. I really appreciate it. It's something I look forward to using more. It's new to us. Like you said, it hasn't been in too long, and we're all getting on the back of it as we go, but it's something I really look forward to utilising for the betterment of our patients and our residents.
Yeah, great. Good words.